Hello, everyone, and welcome to another audio podcast in this series, the audio podcast series around the equity intermission. And this is the Shientist. And today's audio podcast, I'm going to be talking a little bit about the scientists in primary care, and I'm going to provide some of the context, in relating to works that had been peer reviewed and published, and peer reviewed, peer reviewed and published as a systematic review. Some of this work may have has been highlighted previously in some context, but I thought I'd actually provide a bit more of a more sort of in-depth overview in context how this work sort of developed from a sort of a from a literature perspective. Um, so um, So to begin with, just to also highlight, this work is available through the Renal Patient Support Group, the RPSG, and it was peer-reviewed and published in the American Journal of Biomedical Science and Research. And the full title of the work is Healthcare Scientists in Primary Care. Is now the right time for healthcare scientists in primary care as a systematic review. And the works was the publication, the works was published, formally made available in 2020. So I'm going to provide an overview in this way. So a bit of introduction. So healthcare and technology have been evolving rapidly, as is the experience that health professionals and patients who have become accustomed to using it in day-to-day living. So with the current main challenges faced by the National Health Service, or the NHS, being cost and declining numbers of general practitioners or GPs and nurses, there is a demand to better utilize a sort of allied health professionals, or AHPs. And there is some context around this from a King's Fund report that was published in 2018. Expanding on data collection surrounding chronic kidney disease, in particular, would allow more detailed understanding of not only which patients are more suspect or higher risk of specific comorbidities, but also would allow an opportunity for allied health professionals with a sort of a knowledge base and expertise to also be involved at forefront of healthcare. Now, data integration could pave the way for more transparent sort of disease management and smarter screening programs in primary care. So, in context as well, technological sort of advances are known or have been known to sort of revolutionize in some industries versus others, including, for example, the banking sector, which has shown to better staff productivity and performance, reduce errors, and increase customer satisfaction. Technology generally has a valuable resource in some contexts in supporting healthcare. It can streamline services and efficiencies, improve workflow, and sort of present better and present healthcare professionals with what's referred to more sort of positive aspects pertaining to and relating to patient-reported outcome measures. This can be seen with the use of different systems as well. from automated dispensing systems, for example, in and around typically in and around sort of pharmacy practices, to electronic patient health records or electronic patient records or EPRs. Now, however, it's seen that the healthcare industry is generally quite slow in the adoption of particular technologies, and so there is considerable room generally for development, or at least retrospectively there had been. Now, in the United Kingdom, the National Health Service Long-Term Plan 2019 sort of recognizes development and technology uptake would transform the National Health Service, so that digital capability is embedded in routine healthcare, and this includes the provision of, for example, it includes in some contexts sort of app technology, online consultations, and electronic patient records or EPRs. Now, similarly, technology, especially in empowering patient self-management with mobile applications, can be helpful. At present, technology and data integration in the United Kingdom has been inconsistent, and therefore integration of data and analytics will prompt for advancements across several areas of healthcare healthcare for those suffering with particular long-term conditions in future, potentially giving rise to more sort of patient choice, and which health professionals would best support focus of inquiry. Now I'm going to talk a little bit now about some of the aims and objectives of this work. So, conducting what's known as a systematic review over 18 years, the aims of this work, or the aims and the objectives here, were to describe how chronic kidney disease patients currently receive educational support, and highlight what support pathway for chronic kidney pathway for chronic kidney disease patients could look like with, for example, a healthcare scientist involvement, specifically in relating to laboratory parameters, tests, and investigations. This work seek to understand if chronic kidney disease patients could attain more informed education for disease management, and this work finally looked to make a few baseline recommendations and outline if sort of now is the right time for healthcare scientists to be more involved to support primary care and best practices. So I'm now going to talk a little bit around the methodology in how this work was developed. So to begin with, there was an effort where using particular databases, for example, a set of main words, terminologies that related to 3 different categories were used. So, for example, under one category, there was a list of words that related to healthcare scientists. In another category, a list of words that related to diagnostics and screening. And then in another category, there was a list of words that related to primary care. Now, again, the works are available through the Renal Patient Support Group, the RPSG, but suffice to say, for example, Under healthcare scientists, you have typical words like, for example, healthcare professional. You have test experts, pathology, health advisors, researchers, public health, clinical, biomedical, for example. And then under diagnostics and screening, you have words or terminologies that relate to, for example, point of care testing, screening, long-term conditions, chronic illness management, and laboratory practice, and near patient testing, and in particularly under this category, the terminology chronic kidney disease had been inserted as well. And under primary care, there were words, terminologies, for example, primary care and advisors. We had roles, you had commissioning on the National Health Service, and also what's something that's referred to as clinical commissioning groups, or CCGs. Now, so that in that table, there were words that were according to a general grouping of terms or terminologies relating to those different categories, and the words were described. The terminologies were described were used in a combination, really, in a combination of each other to gain a maximum number of papers initially, or publications initially, to identify in according to the main objectives of this work. Now, in the second table, in this peer-reviewed work, there was a list of databases. There was the main project title, title, and then there was a number of papers identified between the year 2000 and the year 2018. As mentioned, this was a systematic review that was done over an 18-year duration. So the list of databases that had been used or implemented to sort of almost churn out the number of papers according to, or the publications according to the different works. The different grouping of terminologies. There were several. So there were several databases. So for example, there was Embase, there was PubMed, there was Medline, there's EBSCOhost, there's Web of Science, there's CINAHL Plus or CINAHL Plus, there's the Cochrane Library, there's the Wiley-Blackwell, there's Scopus, there's SciFinder Scholar, and there's Biomed Central and Science Direct. So those were the databases databases used, and then the project title was inserted typically initially. So the project title again in this work is now the right time for healthcare scientists in primary care, and again alongside that was a combination of the terminologies that I highlighted in table 1, and I'm not going to highlight the number of sort of works or peer-reviewed papers that came out that have been published in relating to those different databases. So for example, Embase, there were 52 peer-reviewed papers. In PubMed, there was 322 papers published. In Medline, through Medline there was 28. In EBSCOhost, there was 622. In Web of Science there was 12. In Signal Plus there was 44. In the Cochrane Library there was 28. In Wiley Blackwell there was 102. In Scopus there was 172. In SciFinder Scholar there was 27. In Biomed Central there was 49. And then in Science Direct there was 23. Now, in line with this, there was as with most research, there was an inclusion and exclusion criteria as well. So the inclusion and exclusion criteria in this peer-reviewed works, has been highlighted in another table, or table 3. So in table 3, I'm just going to highlight in referring to table 3, I'm going to highlight what was in the inclusion criteria and exclusion criteria according to the remit around this work. So in the inclusion, there was papers included healthcare scientists, diagnostic, screening, and primary care. Papers that were multi-centered were included. All papers that are related to humans were included, and primarily the adult population only. Primary and secondary care practice investigations were included. Guidelines, frameworks, policy documents, and NHS National Health Service reports were also included, and papers relating professional integration were also included. Papers that were excluded included papers published in any other language except the English language were excluded. Duplicate papers across different databases were excluded. All papers that dated before the year 2000 were excluded. Excluded papers that had a focus on long-term conditions, healthcare conditions other than chronic kidney disease, were excluded. And full text articles, opinion, book sort of publications, industry papers, and commentary publications that focused on learning disabilities, for example, were also excluded. And so once that was done, a retrospective literature review was conducted over an 18-year duration. A critical appraisal skills program, or CASP program, or CASP, was used to identify papers methodically. Keywords or main words were arranged according to general grouping of terminologies, again surrounding healthcare, scientists, diagnostic, screening, and primary care, as highlighted from tables 1 and 2 in this work. And then table 3, as highlighted, highlights inclusion exclusion criteria, and the CASP was used to identify papers sort of again methodically, and also relevant guidelines and frameworks, policy reports were also included, where they specifically focused on sort of the healthcare science and modernization. Now, in this works, there's another table, table 4, which highlights the literature according to the authors, where publications and authors are from particular types of study, the investigation and the type of methodology, the sample, or whether the sample or the sample size. Then there was sort of an overview around the main the main findings according to that particular sort of peer-reviewed works, and some comments, some sort of additional comments, and then there was a column in this particular table that highlighted the integrity and relevance according to the main objectives of this work. And I'm not gonna spend any too much time highlighting the different studies and investigations that have been highlighted in Table 4, but I will highlight that there were works that came out from the United Kingdom. There were works that came out from the United States. There was works that came out from Europe, for example, Italy and Italy. There was works that came out from New Zealand. There's works that come out that came out from Canada, and there was works that came out from Australia as well. And so after doing that, there is in this work there is a what's known as part of a systematic review. There is a what's known as or what's referred to in relating to a systematic review is a illustration or a diagram which is referred to as a PRISM, PRISM diagram or illustration or figure, which actually highlights the papers that were included, the eligibility in relating to those peer-reviewed works, and an aspect that relates to screening, and then how papers were identified. Again, the works are available through the Renal Patient Support Group, the RPSG, the full paper, but suffice to say, I'm going to highlight some of the main findings from the systematic review. So from the 1,652 papers that were sort of initially identified across several databases, 1,634 paper duplicates were removed, and 80 papers were then further scrutinized after taking out the duplicates for integrity and relevance according to healthcare scientists, diagnostics, screening, and primary care, respectively. Records, guidelines, frameworks, policy reports that did not have a focus on healthcare science and modernization guidelines, frameworks, policy reports, and focus on long-term health conditions and the NHS were further omitted, and the number in that regard was 16. That's 16. Full text articles and reports further assessed for eligibility was 64, and then full text articles excluded with reasons was 46, and full text articles and reports further scrutinized using the critical appraisal skills program, or the CASP tool, was implemented. A remaining 18 papers, 18 papers, were included, and five main themes had been derived, and I am going to talk a little bit about those particular themes. So the main themes. Theme 1 was healthcare science and leadership. Theme 2 was roles, smarter working and collaboration. Theme 3 was CKD, or chronic kidney disease, and primary care education. Theme 4 was skill mix, and theme 5 was barriers to integration. I'll read a little bit, I'll highlight a little bit of some context under each of the themes, and then I will highlight the summary of literature through the systematic review as well. So in context of theme 1, healthcare science and leadership, owing to the present perception or perspective of sort of healthcare scientists, these particular allied health professionals are generally known to be in the background of healthcare. Healthcare scientists are perhaps required who can integrate between science and disease and bridge gaps in health practices surrounding specific issues, specific health issues. So, for example, laboratory tests, investigations, blood and organ donation, for example. Healthcare scientists capable of producing capable of producing first-class science, and how such science transpires to real healthcare require sort of that mutual environment where they are prompted to be more in line with some aspects of frontline practice. So literature informs that healthcare scientists have a broader role in health, with a desire to reach beyond the confines of laboratory practice and to make healthcare more effective. So that's a little excerpt from theme 1. I'm now going to highlight a little bit around theme 2, which related roles around roles, smarter working, and collaboration. So understanding economics and smarter working initiatives would streamline care for those suffering with chronic kidney disease in primary care. At present, however, the evidence base for collaborative working, where healthcare scientists are physically involved, is insubstantial, and these allied health professionals are not traditionally patient-facing professionals. Healthcare sciences as a hidden service remains sort of largely unchanged, and cross-professional and cross-professional collaborative working is questionable, or has been questionable. And in addition, whilst for example web pages such as lab tests online, which is well known, provide patients with information on sort of what tests are for, and why they're being sort of requested from healthcare providers. The climate is right for scientists to identify sort of novel ways of working and collaborating with other healthcare teams. In addition to this, healthcare scientists need to be able to share scientific knowledge in terms that the layman can understand, to help bridge gaps in public understanding relating to clinical scenarios, especially to capture patient-reported outcome measures. There is a broader evidence to suggest that more health promotion, for example, in communities, can support the understanding of some of the complexities relating to health and disease. Scientists will not only collaborate with each other and between sort of health sectors, but can also do so with colleagues on the front line, and the doctors, government officials, human rights and relief workers who are also looking to drive change. And um, there is literature in relating to how different sort of different specialties could be collaborating in a more effectively. So in this paper, in this peer review publication, there is actually sort of highlights in relating to particular studies and investigations as well, and I'm not going to highlight all of those. I'm now going to highlight a little bit around theme 3, chronic kidney disease and primary care education. So professional integration has been highlighted in several papers relating to the care of patients with long-term conditions, for example, those suffering with chronic kidney disease. And where there is a gap in healthcare, professional integration is where, or has been in some contexts, is where scientists' involvement at face value in the care of patients in the care for patients with long-term conditions is important. Modern healthcare is delivered by teams rather than individuals, and requires momentum of healthcare professionals from various disciplines. It is understood that failures in professional integration and teamwork lead directly to compromised patient care and inefficiencies. Professional integration is as much about smarter working as it is about professionals developing best practice. There are multiple interfaces where route of patient care between patients of the healthcare between members of the healthcare team is needed or are needed for safe and effective practice. I'm now going to read a little bit in relating to theme 4, which relates to skill set mix. So healthcare scientists are trained to have a good level of skill set mix to apply knowledge, fulfill sort of those investigations, to implement audits in laboratory practice, validate and authorize investigations. But what is presently witnessed in most National Health Service laboratories today is a systematic reprofiling of skill set mix in the laboratory. Most of the laboratories are now employing more support staff. So, for example, laboratory assistant and associate practitioners in preference to qualified scientists or specialist scientists who are trained to apply skill base across pathology, and these professionals have now been downsized. This means that there are now more issues relating to staff cover, time delays, access to more qualified staff, processes being compromised, more risk management, and general culture and realignment issues. Less experienced or lower cadre laboratory support staff are now required to carry out tasks for which they may not have the skill set, but also may not be in some contexts trained or licensed for, certified for, or qualified for, and competent to perform. And so healthcare scientists play a role in the diagnosis of disease such as anemia and malignancies, involved in sort of blood transfusion services, in around aspects of virology as well. For example, in diagnosing patients with involved in areas of hematology and across virology in relating to diagnosing or supporting the diagnosis of meningitis, hepatitis, and chronic liver disease in relating to biochemistry, and chronic kidney disease and other hematological sort of malformations, or malignancies. So the UK Department of Health, and the organisation referred to as the Institute of Biomedical Sciences in the United Kingdom advocates that patient safety must always underpin the modernisation of careers in healthcare science, despite emphasis on competitiveness and cost efficiency advocated by the National Reviews of Pathology Service. The Institute of Biomedical Sciences emphasizes the need to maintain a robust relationship between laboratory workload and staff numbers. I'm now going to highlight a little bit around theme 5 and the barriers to integration. So several health professional bodies worldwide have highlighted in sort of statements to define roles and the characteristics of a successful team. Patients are undoubtedly interested in self-care and must be part of the communication process too. Early involvement has been also shown to minimize errors and potential adverse events. There is still a misconception, for example, where chronic kidney disease is concerned, and the misconception that CKD is a disease process that occurs in older age. Thus, the label CKD can induce fear and is stigmatizing for patients. Patients will benefit from one-to-one consultations with, for example, healthcare scientists in primary care to help provide understanding of these disease trends. I'm now just going to highlight a little bit around some context around critical analysis, and I will get on to highlighting the main sort of crux around the systematic review, in particularly around the literature in a summary way as well. So some critical analysis. Patients seek understanding of laboratory test information through online support groups, web portals and smartphone apps, and often this is non-evidence based. Health literacy is and can be a barrier, and studies inform online portals are not currently designed or have not been designed to present test results to patients in a meaningful way. And little is known about patients' understanding of results received through electronic patient records. Having access may not guarantee that patients know how to utilize this context, and patients and carers still want more face-to-face understanding of test results, or at least have professionals be part of online support group discussions where they can get more rounded or robust care. I'm now going to highlight a little bit around. I'm going to highlight a little bit around the literature in context of the summary of literature through the systematic review. So one of the main points was that patients suspect or high risk for or confirmed chronic kidney disease not only need access to test results, but also the knowledge behind them. The understanding provided by healthcare professionals relating to laboratory tests and investigations can be confusing. Patients see many members of the multidisciplinary team or MDT at varying times and can receive misinterpreted results. It could be important to see if scientist involvement can provide more real-time laboratory tests and facts, understanding of disease trends with an emphasis on baseline science. The second point surrounding the summary of literature through the systematic review was primary care teams still have issues relating to baseline knowledge and understanding regarding chronic kidney disease as a long-term condition, despite access to frameworks and guidelines involving scientists to monitor disease trends, provide suspect or high-risk patients a sort of more centered understanding, a more centered, patient-centered understanding, which is ultimately encouraged between sectors, healthcare sectors. Another point is there is a need for a review of the current scientist workforce planning and consideration for professional integration, at least from a United Kingdom perspective. And another point was professional integration could open doors to involving scientists more on the front line as part of an update, for example, in surrounding the clinical pathway for those who are suffering with chronic kidney disease. I'm now going to just highlight some of the aspects in relating to the discussion, and some. I'm going to highlight some of the recommendations that this work had prompted. So there was a publication of works that have been referred to in this publication that highlights how primary care could look like in the future. The report informs how it would be important to integrate between different healthcare sectors and professional groups. The report also informs patients want to be partners in aspects surrounding their care. Patients want the knowledge and skills and confidence to take ownership of health and feel more in control of outcomes. The United Kingdom is seeing a continuing and important shift in the burden of disease from mortality and morbidity. Much of the burden, be that morbidity or mortality, is preventable. For example, 2/3 of the improvements to date in premature mortality are related to reductions in smoking rates and high blood pressure, hypertension, and a third due to sort of treatment, including polypharmacy for patients with multi-morbidities. Perhaps now is the time. Perhaps now is the time and role for the healthcare scientists in primary care. The overall conclusion, the overall recommendations, and there were three main recommendations that came out of this work. So number one, healthcare scientists with expertise to be provided further training and qualifications if want to consult with patients and the public through digital platforms. Number two, professional registration bodies and organizations to prompt guideline and practice for healthcare scientists to gain additional certification to provide what would be referred to as soft education relating scientific expertise. And then three, broader allied health professional collaborations are also required to prompt online group consultations, and this is especially important when focusing on the hard-to-reach populations, so for example the Black and Asian minority ethnicities. And so finally, the summary around this is involving healthcare scientists in primary care on how to monitor disease trends, providing patient-centered understanding, needs contemplating owing to burden of particular diseases and other biochemistry-focused diseases. This avenue could open doors to involving scientists more on the front line supporting care, more so for patients with long-term conditions. And therefore there is a need to there's a requirement for a review of the current healthcare scientist workforce in the United Kingdom, and perhaps even a cost-benefit analysis for these health professionals being available for chronic kidney disease patients in primary care. Again, this work is available through the Renal Patient Support Group, the RPSG. It was published in the American Journal of Biomedical Science and Research, there is the full paper. The full paper also has an abstract which summarizes all of the main data. So feel free to access that through the Renal Patient Support Group, the RPSG. I now draw this audio podcast to a close. Thank you for taking the time to listen in. This is the Shientist in this audio podcast on the equity intermission, and this is part of another Storm Robotics production. Thank you for taking the time to listen in.